Good morning, everyone, and thank you for joining us at the Public Safety Solutions for Substance Use Disorder, ECHO, brought to you by the Center for Substance Use Training and Telementoring, CSTAT, at Beeville, Texas. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick housekeeping notes before we begin. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. To help us with attendance, please enter your name, email, and affiliation into the chat. To access the chat feature, click on the speech bubble icon at the navigation bar at the bottom of your window. To all the Beeville, Texas providers, please make sure that you identify yourselves during this session by entering your information into the chat, or if you're joining via phone, please email your phone number and name to beevilletx@yothiska.edu. Also, please note that we're recording these sessions for later distribution through the Beeville, Texas YouTube channel. Any info you put in the chat will not appear in the recording. We encourage everyone to join by video for the discussion portion of today's session. That said, regardless of how you plan to join today, we are just as happy you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6. You can also use the reactions menu in the bottom right of your Zoom screen to raise your hand and indicate that you have a comment or question to share. Or you can use the chat to share your perspective. And finally, please note that no protected health information is allowed in either the chat or the discussion, and that includes names, addresses, dates, pictures, or any information that can easily identify a person. Towards the end of the session, the Beeville, Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and it also allows you to access free continuing education credits. We are approved for CEs for paramedics and any public safety professionals with a behavioral health degree, such as social work or counseling credentials. We are also offering TCO credits this session. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Today's session will start with a presentation from Jeremiah Goulka on why non-stigmatizing language matters for first responders. Following that, we will hear a case presented by Judge Hamilton. There are a lot of professions represented here today, a lot of experiences and perspectives. I encourage you all to share that during our discussion so that we can learn from each other in this space. And with that, we will begin with some introductions. Jeremiah.
Hi, everybody. I'm Jeremiah Goulka, Executive Director of the SHIELD Training Initiative. Glad to see you all here with us again this month, and looking forward to talking to you all shortly in this presentation.
Thank you so much. Julie Parrish.
Hi, everyone. Julie Parrish from the ECHO Program Manager here at CSTAT. Thanks so much for joining us today.
Thank you. Judge Hamilton.
Hello, I'm Judge Hamilton, MIH Department with San Antonio Fire Department, paramedic.
Thank you so much for joining us today. Andrea Hebler.
Hello, everyone. My name is Andrea Hebler, and I am the Program Coordinator for CSTAT. Welcome, everybody.
Thank you. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal. I'm a CSTAT Program Coordinator. Thank you for joining us today.
Thank you. And with that, we will move on to our didactics. Jeremiah, you can take it away whenever you're ready. Thank you.
Great. I'm going to do my little sharing screen thing. Bear with me a second. All right, cool. So you see this screen share full screen, right?
Yes.
Okay. I just learned how to use presenter view with Zoom on one screen, and I'm very excited, and hopefully it will actually work as we do this. So, oops, let me make sure I actually get to where I need to be. All right, let's make sure it's working real quick. Yeah, okay, cool. All right, hi everybody. So like I said a moment ago, I'm Jeremiah Goulka. I'm the executive director of the SHIELD Training Initiative. We provide occupational safety and health training for first responders and other folks throughout the criminal justice system on where the connection between safety, health, burnout, effectiveness connects with responsibilities responding to things like the overdose crisis, stimulant crisis, other areas where substance use disorder and these systems intersect. So we're going to talk about stigmatizing and non-stigmatizing language and why it actually matters. No disclosures, although I mean this is sort of the work we're in this field, so I don't think I've got disclosure to point out here. All right, so stigma and substance use disorder. So, I think folks who are on this call are going to largely be aware that there's this growing awareness of the stigma causes real problems around substance use disorders, mental health. There are other areas where stigma matters, of course, but we're going to talk about substance use disorder here because that's our topic. And within, at least for some first responders, there can be a little controversial. And so we're just going to talk about that from the start. One aspect of it is that, society says to avoid illegal drugs, right? Or avoid using prescription drugs in ways other than prescribed. And by, making that illegal, that is kind of castigating it in a way to say, don't do this. And then plus there's conventional wisdom on substance use disorder that is not always right. So there's this challenge there. The fact that it's, you're castigating this stuff by making it illegal, violations of law tied to illegal drugs, distribution, et cetera. So if somebody is selling drugs that is different from other health conditions, and so that can make this notion of stigma here a little bit fraught for some folks. And then, I mean, to be honest, right, anytime anybody is forced to change their language, it can feel kind of awkward. It can feel like people are waving their finger at you and saying that you're a jerk for how you're talking. Or that you're ignorant, or it can feel like a bit of a forced sort of power switch. So it can be uncomfortable. Okay, with that in mind, it's important to recognize that the harms of stigma are not always obvious, and who the actual victims of it are not always obvious. So let's talk about it and why this matters for us all. All right, so what we're going to do today, we're going to talk about we're going to try to get to these learning objectives: how stigma regarding people who use drugs contributes to burnout among first responders, and then how it can undermine first responder effectiveness. And then from there, how do we use language that actually builds effectiveness, can even fight burnout a little bit, regarding people who use drugs. So this is our goal. See if we can pull it off. So a little quick background on stigma. It's one of those things where I think people kind of have a general sense of what it is, maybe, but it's worth talking about slightly. We got, you can see on the left, there's these key points. It's labeling, stereotyping, and then separating or the labeled and stereotyped people away from everybody else in ways that harms them. So on this graphic on the right, it's taking these thoughts, attitudes, beliefs, and leading to discrimination. I'm going to talk about these three levels in the next slide, but it has a whole array of impacts in the way it can really harm people in the way that they get separated from family, professional opportunities, society, stigmatizing them, how it can lead to barriers, like really significant barriers in meeting basic needs or opportunities, to get out of problematic situations, contributes to poor health, contributes to high level of stress, which then themselves can trigger more chaotic use. So, okay. Let's talk about it on a specific harm of stigma, which is that for people with substance use disorder, the stigma can actually interfere with progress. It can hurt. It's a hurdle for stabilization and recovery. One way is that it causes people to seek less help. Why? Well, on this notion of individual stigma, it means that people who should be providing support, we're talking across the whole world here of experience or somebody. It's family, it's society, it's if they're interacting with people, with first responders, it's with healthcare providers, et cetera. Those folks are who you would think should be providing support are actually not succeeding or outright failing to. It creates institutional barriers. One thing that's really obvious is that well, at least once you look at it, if you're not already aware of it, is that medications for opioid use disorder or medications for addiction treatment can be really hard to access. And, why are they so hard to access? Well, essentially it comes down to stigmatizing people with opioid use disorder and not trusting them. So methadone clinics, you have to go to the methadone clinic. You can't just get a big prescription for methadone. You can get prescriptions for Suboxone, but there've been all these limitations on who can prescribe and how you get it, et cetera. Addiction medicine is like a fledgling field. It's hard to access, get doctors, therapists, et cetera. And then internalize, this is an important thing to know, is that if the world is stigmatizing you, then people start turning it in on themselves. And so that can then lead them to say, why bother? Everyone's calling me a lost cause. Maybe I'm a lost cause. And when you connect that with the underlying anxiety, depression, et cetera, that underlies substance use disorder for a lot of people, it's making things worse. And so there's a study that where several people with substance use disorder were interviewed, and they pointed out, this is a first responder relevant piece, that EMS and hospital providers were giving stigmatizing treatment and low empathy towards people who use drugs. And that was a key reason why they were turning down transport, as well as anticipating that they'd get inadequate care. That was 2 of their 3 big reasons. So it's interfering with effectiveness. The interference with effectiveness, it's also causing burnout. And this basically creates a public safety and a public health problem. Okay. From a police point of view, my colleague Leo Beletsky's research has some of these quotes that you can read here that are essentially highlighting how a sense of futility can arise in the work, doing encounters, responding to calls with people with substance use disorder, that this sort of same negative cycle gets going, and it takes away the energy to try for change, try to make a difference. And so that leads to this negative feedback loop. You've got a high frequency of calls that are related to alcohol or other drugs. Oftentimes, folks just don't have enough training about addiction, understand how it works, or recovery science to see how you can make a difference. They don't know of adequate tools, or they don't have them, or they don't know about them. They don't know how to use them. This creates a sense of futility. Why bother? If you think you can't help, why bother, right? And then as that goes, there's a back and forth feeding here. Because if you really think you can't make a difference, then you're like, okay, well, if I can't help so-and-so, then so-and-so is a lost cause. Why am I to bother help so-and-so? This back and forth. Interestingly, can create a susceptibility to misinformation about different substances and substance use disorder and the possibility of treatment, which can then actually create stress loads that officers and first responders have to carry. Bringing the science to folks on that is one of the things that our SHIELD training initiative trains on. This can then lead to lousy interactions, lousy response on calls. If people are not bringing their best game to it because maybe they think they can't help already. They're worried that somebody is going to be more dangerous than science would suggest they should worry about. So you can see people having a shorter fuse, being more likely to escalate or fail to de-escalate. So you can building less connection, using or offering fewer evidence-based approaches and kind of skewing towards things that are more punitive and ineffective. And so you have less good downstream effects that kind of come from that. And then it just keeps this, it's a negative feedback cycle. It keeps going. And there's research that then ties this to burnout. So there's 3 pillars of burnout. So one of the most important ones is this: it's the low sense of personal efficacy. If you think you can't do a good job, you think you can't make a difference, that creates a lot of burnout. If you're out in a situation again and again, and you think you can't make a difference. And I'm sure a lot of people here have felt that sometimes. And so the question is, like, how much does that burnout rise? And there are ties between this, that aspect of burnout, and stigma. And there's another piece here: emotional exhaustion. They're interrelated. You can imagine, you think you can't make a difference. You're in tough situations. It's just, it makes it harder to bring your best to the encounter, and it leaves you drained afterwards. Then there's this concept of depersonalization, where you're not dealing with a person who's very burnt out starts building these walls, seeing somebody as more of just kind of a number versus a person they can help. This is a situation no one wants to be in, and no one gets into the job to get there, but that's how burnout works. So there's some interest. There's not enough actual research on this among law enforcement and EMS. There's there's research on stigma, there's research on burnout, but not as much on the connection that we would like to see. But there is among substance use counselors and healthcare professionals, folks in that are labeled as caring fields. And that research shows that folks who got demanding caseloads, so that's like high numbers, tough cases, inadequate resources, and inadequate addiction education, you would think that people's education levels on this would be higher than it is. Those altogether reduce that sense of professional efficacy, which increases provider burnout, and then leads to less good treatment and treatment outcomes. There's some research on probation officers. I saw there are a number of probation officers on this echo today. Some research there has found that looking at mental health stigma, that there's a tie between burnout, stigma against folk with mental health disorders, but also who have that feeling of low competency, low capability to help the folks with those disorders. So, improving on any of these can make a difference. So let's talk about, how do we do that? How do you reverse this cycle? Let's get out of that negative cycle. Reduce your burnout, be more effective. One of the main ways to do it is just boosting knowledge. There's a number of people out there are not actually aware of the fact that addiction is treatable and recovery is possible. Overcoming that is important. Providing more science-based addiction knowledge and recovery science knowledge, that's a new field basically, is really important to overcome conventional wisdom problems where it's not accurate, to fill out a person's knowledge about addiction. Because there is a lot of training out there, but people may not be getting enough. And then there's another important thing to remember, and which again might be obvious, is that first responders are, you're generally not seeing the success stories because they don't necessarily come up in front of you again. You don't see people who manage to get their lives kind of pulled out of chaotic substance use and into a more orderly recovery framework, or a thriving in recovery, they don't come up as often in front of you. Sometimes, it happens. Sometimes it, there may be a bump in the road and you encounter them again. Other times, maybe you're just lucky that you encounter them, on the street, and maybe even have a conversation where someone can say, hey, what you did helped, or what your colleague did help. But generally speaking, if you're only seeing folks kind of in crisis, it's hard to get that sort of deep belief that it's going to get out of crisis. So that's a piece. Another is just the tools. Folks often aren't aware of tools that are available locally. There may not be enough. Most places don't have enough resources. But when to the extent that they're there, there's a lack of awareness about them. There can be stigma about them. But knowing how to access them, how to have the skills to do that is often inadequate. And so developing that really boosts effectiveness, and then the sense of effectiveness, that personal sense, which is a really excellent way to reduce burnout. There's a bunch of research substantiating that. For instance, so even training can make a big difference. So even at the point of training, you can feel like some of that burnout is getting addressed because you already know, hey, these are some tools I can use. And so building self-efficacy reduces burnout, reduces stigma. So, these are all kind of win-wins to get onto a positive cycle. Okay, so this presentation is about language. Well, I think, and the reason why I did this is that understanding the importance of language it's part of this bigger whole. It's not just the language alone, it's how does it fit into the big picture. So, but language it can often be the most obvious way that you can flip the script, so to speak. And so let's just look at why the words matter, because I think that sometimes when people get told to use different language, that they're just kind of told to do it because if they're not doing it, they're being a jerk, as opposed to explaining why it matters. So here's why, are some examples of why it matters. So one is that stigmatizing language can actually it can act as fuel to your own feelings of futility and burnout. If you're using words that basically kind of have an implied guaranteed failure that you can't make a difference, it's going to take away some of that notion that you can make a difference. We'll get into specifics of language in a moment, but that's a key. In the process, if you're bringing that kind of negative language in, you're going to have reduced quality of interactions with with people with substance use disorder. As partly, as we said before, you're kind of going into a burnt out state. Your battery is basically empty. You've already got enough on your plate. You already had a really busy day. But you're also signaling. There's a signaling effect. You're signaling to the person you're encountering that you are disrespecting them from a start. It can be hard to build a bridge. More on that in a moment. And it kind of inherently reduces follow-up options. One, because if you're not thinking you're going to try hard, less good downstream effects will come with that. And then also a person might be less likely to use the options you're offering, if you do offer them, but you offer them in a stigmatizing way. Okay. Non-stigmatizing language. Here's the good stuff. So if you're using better language, actually has all these benefits to first responders, because it's first of all, you're taking some of that cynicism out of your moment, because you've kind of removed that notion of guaranteed failure. You're increasing a possibility that you can engage somebody in a respectful way that's actually more, maybe you thought you were being respectful, but now you're doing an even more respectful way that can help increase the likelihood of a safe and effective encounter, easier to avoid escalation, easier to keep things safe. And honestly, you can use it almost as a cheat code. Maybe your knowledge isn't, all the way up there. Maybe internally you are having stigmatizing thoughts, but you don't want to have them come out to the person. It's like a cheat code. You can use a better language. And part of what it does is it's the signaling effect that shows that you clued in, you care, you've bothered learning, and you're not like everyone else, because a lot of folks with substance use disorder who you encounter may have had many previous encounters with first responders, right? And so showing that you're clued in or you're trying can show that you're not like everybody else. And then maybe that person you're encountering is like, all right, I'll give this one, I'm going to listen to you more than I have previously. And like I said, we can help the process reduce burnout. I'm not saying this is all like, the magic silver bullet that's going to reduce all of your burnout and fix all the encounters, but it is a tool. So how do we know if you're using more effective language? There's basically two key questions. Is it a neutral phrase you're using, or is it judgmental or negative inherently or in its connotations? And another is, does it imply that somebody's in a permanent kind of bad state or that change is possible? I don't know if you have this situation, but I have with my kids where, at school, it's all, you're not supposed to say things like calling somebody dumb or stupid and things like that. And at first I was like, why? Like, who cares? That's what we all did when we were kids. But then I finally realized that it was about that sort of state thing. If you're saying somebody did not know a thing and then you call them stupid, it doesn't mean, you're actually saying you're in a permanent state of lesserness as opposed to a temporary moment of ignorance that you haven't, learned from yet. And that can matter when someone is hearing these negative things all the time. So these are two different questions, but with some of these different pieces of language, they will both factor in. So it's not always obvious, right? So some of the things that you'll see in these guides, you'll be like, oh yeah, I can see that. And others are like, wait, I know I've been like this, like, why? Like, what's the problem with that? It's one of those things where we can kind of only know the impact of words when you find out from the people impacted by them. And there are a bunch of guides where I'm going to provide links to some of them at the end so you can go check it out and not have to work it all out yourself. So I know I'm at 22 minutes. I've only got a couple slides left. So we'll just do a couple examples here. So you can here's an example, a person with a substance use disorder versus a substance abuser. I think you can probably quickly say, oh, I wonder what Jeremiah is going to say is a good one versus a bad one here. Well, there's actually been some studies on those specific terms where hundreds of clinicians were surveyed to see how they would, what sort of treatment course and what were their attitudes about the person by randomly assigning the two different terms to people in cases where the fact scenario was the same. And there was a very significant difference in how it came out. So the people who were labeled substance abusers, the clinicians saw them as less likely to benefit from treatment, more likely to benefit from punishment, less in need of treatment, which is interesting, as if they could just take care of it all themselves, and more to blame for their condition and more dangerous than people labeled as having a substance use disorder. So this just shows how this stuff can really matter where the rubber hits the road. Another one is, say, drug testing, testing negative or positive versus clean or dirty. That's one of those moments where here negative or positive is testing is more neutral than saying clean or dirty, because those have just stronger connotations that you just kind of remove the connotations, and then if you kind of drill in, you can see why those connotations can bother people who are stigmatized. Similar dynamic with calling someone healthy or in recovery versus clean or sober. This one I find interesting because it took me a while to understand why relapse was a non-preferred term. And I finally clued in that the term relapse has this connotation of presumed failure. Like, it's this presumption of failure. Now, recovery science says that returning to use is a predictable bump in the road that can be addressed. And it often reflects a treatment path that didn't work right, difficulties with what, maybe there was the wrong medication, maybe they lost their insurance, or Medicaid didn't cover something, couldn't get the treatment, etc. It's a moment to reform your treatment path. But relapse implies failure. And then you see terms that are a bit more aggressive, like meth monster, and ones like that actually can really matter for on operational responses, because the more kind of implied aggressiveness in there, the more likely you're going to have a notion of that your safety is very much at risk, and it might be more likely to take a jump to, say, a use of force or restraint that just isn't actually called for, which can put first responders, by taking those steps, actually puts them at much greater risk to their own occupational safety. So there we go. I guess the way to just sum this up is that better language does lead to better outcomes. It can be, in a field that is rife with burnout, it is a way to try to just scratch away at some of that burnout, improve some effectiveness. And the more you learn about addiction and recovery science, the easier it is to kind of grab onto the kind of better language, because it just becomes a little bit more obvious feeling. And then, as I was mentioning on the cheat code, when you look at these testimonials of folks, say the first time they go to a harm reduction facility, or they talk to a peer coach or a recovery guide who treats them with like real respect, how it can be this kind of really basically tragically wonderful moment where they say how it was amazing to be finally treated with respect and treated like a human. It's beautiful, but it's profoundly tragic, right? Because why is this new? Why is this a first time? It shouldn't be that way. And this can help have better interactions that way. Okay, so here are 4 sources. This presentation will be sent around, and you can kind of click to it from there, or maybe what I'll do is put these 4 links. We can put them in the chat, and you can check them out. There are a whole bunch of different approaches. The HIDO one it's kind of specific to stimulants. The dictionary is quite long, has a ton of information. Shatterproof has a bunch of really useful backgrounds, and changing the narrative goes into a lot of what we call tired narratives, and it's pretty useful. So references will be there if you want them. Thank you very much.
Thank you so much, Jeremiah. That was an excellent presentation. We do have a bit of time, maybe a couple of minutes, for any questions or comments from our learning community here.
Well, thank you, Jeremiah, for everything that you provided us with the stigmatizing out there that we deal with regularly. I do notice that with our program, we see a lot with stigmatizing within the family. And when we approach these individuals, sometimes we find ourselves trying to give resources for the family, because that's a risk that once we get the patient into treatment or services, it's almost a battle, them going back into that environment within their own families. Do you have any resources or comments as to how we can help those folks out?
I am providing these links here. That's an excellent question, and it's obviously something that when we talk about the problems of conventional wisdom, like people remember, of course, that show intervention, as if it's a notion that that's how it's somehow going to be a helpful, that kind of intervention approach is going to be a helpful way to basically have your family all get together and like yell at you to say you have a problem, there's something going wrong in your life, as if that's a news flash to people who are struggling with substance use disorder. We've got this kind of cultural problem, and so I think hopefully some of these resources here, I put them in I guess 4 different little things in the chat there, could help. I'm sure there are specific resources that are like for families that talk about how to help and how you're actually making things worse. And if there aren't, there certainly should be. It's I don't have like any obviously magic answer. If there was a magic answer out there, I think would be sharing it. But yeah, those resources are helpful.
Yeah, no, I see them here. Thank you so much.
One thing I could mention, related to that is that in our work, we've seen that when police do outreach and coordination, like co-outreach with folks who are behavioral health workers, that often the kind of in places where that happens, the sort of best practices are to let the behavioral health worker lead. But one of the things that the law enforcement can often offer is talking to family, and so having some of this knowledge as well as resources to provide family members can be a way to reach family members, but you need to have some of that at hand and ready to share.
Thank you so much. And thank you again, Jeremiah, for this wonderful presentation. You can keep putting the questions in the chat, but in the interest of time, we will move on to the next part of our session. Karen, if you could please bring up the announcements from the BWEL program. Thank you so much. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge that your organization is encountering and receive expert feedback from our hub members. There is no need to prepare a formal presentation. We will provide a case form to assist with your case presentation. You can email us at cstat@utisca.edu. Next slide. The 2024 Texas Substance Use Symposium is officially open for registration. This free event will feature complementary continuing education, curricula, interactive panel discussions, and professional networking with national and Texas-based substance use disorder experts. Texas is also open to sponsors and exhibitors. To learn more on how to become a sponsor or exhibitor or to register, please visit texas.org. Next slide. Join CSTAT and the Texas Health and Human Services for an 8-part webinar series to explore the intersection between behavioral health, substance use disorder, and COVID-19. Our inaugural session, Preparing for the Triple Threat, Rising Rates of RSV, COVID, and Flu, is on a Friday, February 2nd. You can register for this free webinar session and our upcoming webinars by visiting cstat.utisca.edu, and we will also drop the link in the chat. Next slide. Please join us for our next ECHO session on Thursday, February 8th. We have an interesting session lined up. And with that, we will move on to our case for today. Karen, if you could please share the case form, and Judge, you can take it away whenever you're ready. Thank you.
Oh, no worries. Yes, ma'am. Thank you. Today, we're going to be doing a case on a 42-year-old male heroin user times about 5 years. He was using up to 2 grams a day whenever we made contact with him. His first interaction with 911 appeared to be in 2021, where he was given 3 doses of Narcan on scene. It didn't pop up until about a year later when our teams started interacting with him. So a little background information before I start. The day before was one of the first contacts that we had for him in about 2 years. And so he had taken heroin just a few hours before our teams arrived. So he wasn't able to get the Suboxone treatment. So Dr. Miramontes had ordered some clonidine and some over-the-counter medications for this gentleman. And so where we come in is the next day, it was myself, our MIH lieutenant, Sam, and then two employees of Be Well, Texas. Very excellent people. It was probably the best ride out that we've ever had. They made it enjoyable, but it was Charisma and Brittany. And so we made contact with the consumer at his sister's house because I believe he was homeless and staying with her. He had not used since 6 o'clock the day before. And so we did a COW score on him. It's a clinical opioid withdrawal scale, and it was about 6. Dr. Miramontes was called and ordered Suboxone treatment for him. So we were able to interact with him and get him some Suboxone. And with the Be Well Texas people there, that's whenever we were able to set them up with them as well. So that's just a little background information on that. Go. And did you want me to read from this, the little list that I had given you previously?
You can just summarize the key points from the case, and we can have the community ask questions if they need to.
Okay, and yes, ma'am. When we got on scene, we could tell that he was in a little bit of distress because, I mean, 2 grams a day, almost, it was probably about 28 hours since he last used. So you could tell that he was really in a hard spot. So we were able to talk to the sister and him, do all the vital signs on him and everything like that. And after we gave the Suboxone, which I believe was 16 milligrams of Suboxone, after about 50 minutes, he did started to feel a lot better. So as I wrote in here, using the team approach, we listened to him. It's always good to praise them, of course. You know, hey, you're seeking help and everything like that. And once they start to get to trust you and know that you're there to help them, and the presentation before, the stigmatism and all that kind of stuff, once you, I guess, get rid of that and they're more open to listening to you and stuff, I think that's what creates the little bond between you and the consumer at that moment, to where they're able to trust you and to take the medications and then get on their journey to recovery. But it all starts with those kind of interactions. If it's a negative one, the chances of them calling you back are pretty slim. And so I think we did a very good job with this person on that day. And so your Be Well Texas employees were very helpful on scene as well. They were also able to interact with the consumer and set up a time and I guess, the date to meet, so they could handle it on their aspect as well. And then as a follow-up, we did go and dose him a few more times until he was able to go to those facilities. So that was just a little, I guess, background of the case that particular day that we went on. So that's about it in a nutshell there.
Thank you so much, Judge, and thank you for sharing the case with us. And I now open the floor for any questions or comments from our community here.
Can you reshare the second page of the form?
Sure. Karen, if you could please share the form again.
Thanks. I just needed to look at it. Well, since we've been talking about language, I don't know if Judge, if you want to just kind of dig into that a little bit more about how how you see language mattering for you and your peers, and kind of what works, like how it matters.
As far as language goes, I with me personally, and from what I've seen for those who are really good about it, is developing that rapport and not focusing so much on, you know, the usage itself. It's the recovery part. So you use the language of, the positives, and not, hey, you're an IV drug user, all the stigmatism, like you said, that goes along with that. And it's, to me, it's the praise of, getting yourself back on track and things of that nature. I don't use any kind of negative kind of terms when it comes to their past usage. I try to focus on the future and the recovery aspect of the whole interaction.
Thanks. That's really helpful.
So I had a question for you, Judge. You had mentioned that, in the second page of the form about what the success would look like for the patient. What is the patient's goals for himself? What did he want?
I know that was a few months ago. So after talking with him on scene that day, he was very adamant about wanting to stop living the life. And I include in here the one thing that I try to emphasize to anyone in this situation is, first and foremost, you have to separate yourself from the situation and the environment. And the problem you run into is, it's in their neighborhoods that they've grown up with all their lives and stuff. And getting out of that environment where your family and friends and everyone, it's very difficult, but it's also very important for the success rate. So I remember telling him all that, you probably have to remove yourself from the situation to get clean, and another part of town where this heroin's not as prevalent, kind of thing. I do remember that, but he was very receptive to any kind of information we had. And he was very adamant, like I said, about remaining or getting.
Yes, John.
And so just wanted to add on to what Judge is saying here. I followed this patient for about 6 days as the program manager for this program for the overdose prevention with San Antonio Fire Department. And I engaged with this individual and the family twice, once before Judge and the team went out, and then a couple of times after via phone calls. And Josh, you asked, Jeremiah, I'm sorry, you asked what was his motivation. So I did ask him what were they, and he wanted to reconnect with the family, wanted to get a job, wanted to go back to school. I don't know if those were just statements that he expresses with law enforcement or people in uniform. His family, because he lived with his sister, and the sister also was a very like the mother hen for the family, wanting better for her brother. she also expressed that she wanted him to kind of just start working. And so getting a job and providing money for a household where the family is struggling on trying to support two children and possibly a grandchild in that same house, was typically their motivation for trying to get help. Now, whether the family was more motivated than he was, that would have to be determined after he gets into services, or starts getting treatment, where he gets peer support and maybe some counseling. Furthermore, just to add, like I said, since the time that he overdosed, our team engaged with him. Let's see here, 1, 2, 3, 4, 5, 6 times before we got him into services. And so that shows success on our end, that he is receptive to our engagements or meeting up with him, introducing his family to us. I think that if there was anything that we could do different, maybe collaborate with the organizations here in San Antonio and maybe target those areas over there where there's a presence of services and community outreach for them, where they can see that there's help out there when they're most vulnerable. It's unfortunate that we can't always just go meet directly with them anytime that we feel like we can. We're constantly looking for trying to provide these services for anybody who overdoses in San Antonio. So, but when we are in those areas again, these folks do congregate around each other and they do remember us, and so that's an effort that can be built up a little bit more here in San Antonio, but it's there, and we hope that they are aware of it, that they can reach out to us when they need the help.
Thank you, John. Any other questions or comments from our community here? Or if you encounter similar situations and you could share what you've done. Guess we all need a cup of coffee. That's what I'm feeling. Everybody's super quiet today.
I'm gonna guess that either means that everybody already knows this stuff and they're like, yeah, okay, waiting for the more interesting hub, or possibly that we're just so controversial, like I don't even want to engage it. I hope it's the former.
This is Diane Thomas. I do have a question. For John, this is probably for you, the overdose prevention team that's located in San Antonio. Can you tell me what that team consists of? I just want to check to see if we're tracking that kind of team here in Bell County.
Absolutely. So our team consists of 4 medical directors that we consult with on treatment plans when we engage with an individual who wants help. We have 2 separate teams. One is a opiate team, and the other one is a polysubstance. Now, our patients or our clients who we address sometimes cross-pollinate between each team. So both teams are fully capable of performing interventions with the patient, regardless whether they're opiate or some other type of substance. Typically, we come across patients who are mixing the 2 drugs, either a stimulant or depressant. And so in that case, we do evaluations with them, just like any EMS unit would. We follow our protocols through the San Antonio Fire Department. And then we are capable of initiating treatment just like any EMS unit. So we're fully capable of handling any situation that EMS would be able to. The only thing that we don't do is we do not transport. This is not a 911 call. It can typically be a crisis call or someone just seeking help. And so we engage like that. But at any point in time when our team is out in San Antonio, they can divert from a scheduled plan of what we're trying to do and trying to engage with these patients that overdosed over the last 72 hours, and they can go directly to a 911 overdose. Just yesterday, one of our teams did that, where we had EMS, police, and our team all arrive on scene with the patient who overdosed. And so in that case, we would definitely be entering that patient into services or into that continuum of care with our team being there at that time of the 911 call.
I see a question here from Lindsay. Do you have any certified peer specialists on your team?
So we do have peer support specialists. We team up with SACADA, San Antonio Council on Drug and Alcohol Awareness. They do ride out with us every Wednesday, as well as we also make ourselves available for Corazon Ministries, who addresses the homeless population, where people who use drugs, there's a big population for people who use drugs and with our homeless group out there. And so at any point in time, the nice thing about what they do is they have a resource hub where they can bring them into their resource hub and start addressing either wound care or harm reduction efforts, while at the same time be able to reach out to our teams who are mobile and get one to go over there to respond to someone who potentially might be in withdrawals and might meet criteria for treatment, regardless of whether it's opiate or a polysubstance type of run.
Thank you.
I have one question.
Mhm.
Hi, my name is Cynthia Mendiola. I have a question, sir. Do you find in the community, San Antonio community, that there are individuals that at one point had problems, substance use disorders, but with cocaine, and they come out from incarceration looking for the same substance they had at one point, but end up seeing that now it's an abundance of methamphetamine? Do you find them, having to, resort to the meth instead of the cocaine?
Absolutely. That population who's coming out of jail, it comes out with the stigma as to whether they're going to be able to get a job. It's difficult for society to accept them. And so their coping mechanism, if they don't have good coping mechanisms, they tend to use any kind of substance that's going to get their mind off of whatever stressors that are coming their way. To the environment that they were in before is the only environment that they know to go back to. And so we hope that when an individual comes out of jail, they gravitate to the peer support systems or the peer support organizations that are out here. If they're coming out and they're being homeless, we hope that they move towards either Haven for Hope or Corazon Ministries for that peer support. And at that point in time, if they disclose that they're using drugs, then the peer support over there reaches out to us so that we can enter them into a larger continuum of services. And so that's how we address that. And ultimately, yes, we have come across some of our patients who just got released from jail and went back to using drugs, or were feeling like they were tempted, but they were trying to refrain from doing that. We also have a good rapport or partnership with Bexar County Behavioral. So with that being said, individuals who are not necessarily struggling with an opiate disorder, or whether they are, there's also additional services being provided through them. If they disclose that with us, then I connect with the behavioral health from Bexar County to see if we can get them into inpatient services if that's something that they desire.
Thank you, John. And we do have a couple of questions here from the chat. And I think this is for you, Jeremiah. Do you have any recommendations when working with people, with groups of people that experience a lot of stigma and bias, especially in these situations?
Well, I guess it depends on who who's doing the work? It's a big question.
It is.
One is, I mean, I obviously I would recommend what I recommended in the talk. It's build that knowledge of recovery science, and the tools, find out what the local resources are. So whatever whatever the person is and where they can work, where in this ecosystem, if they're inadequately connected to others in the ecosystem, which, is normal. I mean, we're seeing on this call already, but we've had these conversations like, what do you do? What we can, how can we interact? How can we connect? I mean, the different task forces that exist and stuff, like having those relationships to know what is available locally, hugely useful. And then, how you can connect to them. And then, like we said, kind of scrubbing out some of the bad language, and then, following on what Judge said, about, leaning in on praising the good stuff. There's a whole lot of, I don't know, the sky's the limit. There's so much we can do. I would like to give a shout out. We work with a lot of places across the country, and there's a lot that is happening in San Antonio that is really actually on the kind of national level, kind of cutting edge. And particularly like some of the stuff that's coming out of UT Health and the EMA and the emergency department, and the rapid Suboxone induction and stuff. I mean, it's good. So there's still a lot to be done, but praise where it's due.
Thank you.
Thank you. And just before we wrap up, do you provide any harm reduction supplies, such as safe use supplies, clean needles, first aid kits, etc.?
Is that for San Antonio?
Yes.
So we do not supply safety needles or exchange needle program. Corazon Ministries, they seem to be the organization that is capable of doing that. So when it comes to harm reduction, for a patient who is not necessarily ready for treatment, we refer them over to Corazon Ministries. However, on our end, as far as harm reduction, we do flood San Antonio with Narcan for any individual who is needing, who we feel that, or if they express that they're opioid users, that they do get Narcan, as well as we take it to the next step of trying to get them enrolled into services, and providing that larger harm reduction effort by getting them started on Suboxone, which definitely stops them from those cravings and the withdrawals over a 24-hour period until we get them into the clinic.
Thank you so much. And Jeremiah, if you could please give us a quick summary before we wrap up this session.
Sure. Cool. I'll be super quick because I know we're coming on the end here. All right. I took some notes. Let me open them up. All right, cool. So I think we had a nice time today talking about stigma issues, and again, like Judge Hamilton talked about, how praising the positives help, how much that's important. The particular case showed how some of the those I was mentioning the areas where there's leadership happening in San Antonio. It also highlighted how multiple interactions are often needed. There's one of the mistakes that you see nationally when some folks start sort of seeing the light on how you can help fight against substance use disorder. They may kind of jump in and be like, all right, I'm going to do this thing, we're going to have this interaction, and we're going to solve the problems. And well, it's not really how it works. So multiple interactions are often needed, and it's really good when you're going to have an interaction with someone who's had a non-fatal overdose, because then you're going to be able to that's a person who's in kind of maybe critical need, and building a relationship. It may take, like we said, multiple interactions. And then through those interactions, you're building relationships in the community. So like John, you said that maybe people out there know that we've got some of the services you offer because word of mouth gets spread. And so I think we've answered pretty well the original question from the case presentation was is treatment enabling. I think treatment is, empowering. We should, you talk about empowering and the chances for someone's life to, help get, with the pathway towards and then onto recovery. It's needed, but it can be a bumpy road. So thank you all for being here and joining this ECHO and for wanting to learn and for the work you do. It's hard work you all do. So just want to, give you all some props. Thank you.
Thank you so much, Jeremiah. And thank you all for joining us today for this ECHO session. As a reminder, to earn continuing education credits, please complete the post-session survey using the link in the chat. If you would like to present a case, please email the BVAL Texas team at cstat@utisca.edu. We look forward to seeing you at our next session on Thursday, February 18th at 11 a.m. Central. Have a wonderful rest of your day. Thank you. Bye-bye.